We are live now, ma'am. Please start, ma'am.
So good evening, I'm Dr. Meena from Lakshmi Madhavan Hospital. And today's topic is a case presentation on prolapse or pelvic organ prolapse, actually. And actually, if you see the prolapse is it's the most common gynecological complaint we come across when we tackle postmenopausal women or the geriatric OP or even in the younger age group. And if you see the incidence, it varies actually from 2% to 48%. And this has been epidemiologically categorized as pelvic organ disorder, which has got a chronic illness, but it is non-fatal. So the significance implies that we should discuss and go into the details of pelvic organ prolapse, the latest, what are the latest things on prolapse and the POB classification, etc., etc. So our student, Dr. Sajani will start the presentation now, a case of prolapse or pelvic organ prolapse. So over to Dr. Sajani.
Ma'am, I request Gayatri ma'am to introduce President and Secretary of the societies. Gayatri ma'am.
Yes, you can. A very good evening to one and all. As Meena Madam has already said, this is one of the very, very common complaints we are going to encounter. And for postgraduates, this is a very common exam question also. And on this occasion, I request our President, we'll go to the next slide. Ma'am is not available. Yeah. Our President, Vidya Prabhakar Madam, to say a few words about our BODHANA. Vidya Madam.
Good evening. Yeah, good evening, dear all. And so this BODHANA program, of course, is for the PG students, as we all know. Of course, many of the younger consultants and even the older consultants can have a few tips from this, because whatever is coming up new in any field, the change of ideas, the change of paradigm change, everything will be useful for everybody, although it is targeted for the PGs. And I think our TNFOG is doing a wonderful job of taking up this teaching for all the PGs, because it is very different in different institutions. There are some institutions where the teaching is very strong. There are some institutions where they may not be as good. I mean, the academic programs that are going on in their particular college. So this will be like uniform. And we have some very senior teachers over here who will be questioning them. So I think it is a wonderful opportunity for all the PGs, because we didn't have these kind of opportunities when we were PGs. So we were only dependent on our own seniors, whatever they said. So we never had any concept. Suddenly the external will come and ask some few questions, which will be her pet questions, but we will not be knowing. But here, since different teachers from different institutions are going to talk, it's really very beneficial for all the PGs. I wish all success for this program. And I wish actually today, I think there are more seniors than PGs. I hope they'll be joining very soon. And thank you all.
Thank you very much, Madam. Next, I would like to call upon our beloved Secretary, Sampath Kumari Madam, who's been a pillar for all these programs, to say a few words.
Anyway, she has told, no problem. All the best. We'll start.
Okay, ma'am. Yes, thank you so much, ma'am. And now over to the presenters.
Dr. Sajani from Lakshmi Madhavan Hospital.
Please introduce the internals and externals, ma'am.
Sorry. We have with us as internals, we have Dr. Madhubala and Dr. Meena. They both are from the Lakshmi Madhavan Hospital, Tirunelveli. Madhubala Madam is a senior consultant there, and she's also an alumni of the Stanley Medical College and Ramchandra Medical College. And she's passionate about teaching. And she is the one who's organized getting 2 DGO seats each year from the National Board of Examination. And her main field of interest include high-risk obstetrics, laparoscopic and hysteroscopic surgeries, infertility, and IVF. She loves and practices everything in the field of her practice. Next slide. Meena Madam, she has done her MD, DGO, DNB from the Tirunelveli Medical College, Madurai Medical University, gold medalist in the MD, and completed DNB in 2001. She's got more than 21 years of teaching experience for the undergraduates and postgraduates. Was Foxy TVL president from 2014 to 17 and she has presented many papers in many conferences and has been a faculty in most. She's the gold medalist of her batch in her MD. We're so pleased to have both those internals with us. And for externals, we have Hepzibah Madam, who requires no introduction at all for all of us. And she is the past president of Obstetrics and Gynecology Society of Southern India, past president of Chennai Menopause Society, and past chairperson for Education Committee, Joint Treasurer IMS. She's received 2 consecutive years Best Society Award. She's published many papers in national and international journals, and she's been an invited speaker in many national and international congresses, and she always makes sure that she does adequate justice to whatever topic has been given to her. She's also authored a lot of chapters in textbooks, etc. And she's got a lot of awards to her credit. A.L. Mudaliar Award, 1985, C.S. Dawn Award, Lifetime Achievement
Madam
Award.
Gayatri, go ahead. Go to the next speaker.
Along with her, we have Dr. Kalyani Sai Dandapani Madam, who is the Principal Chief Medical Director and Chief Gynecologist in the Southern Railway Headquarters Hospital, Chennai. Okay, ma'am, we'll go now to the presenters. Yes, Netra Lavanya, if you're ready, please start. Sahiti, you can stop the screen scene.
Netra ma'am, please start sharing the slides, ma'am.
Is it Dr. Netra or Dr. Sajni who's coming first?
Both of them were with Dr. Meena ma'am.
Okay.
They're representing.
This is an distance. Somebody say that side.
Are you able to see the slides, ma'am?
Yes, you can go ahead, madam.
Yes,
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 ma'am.
but it's
Yes,
not in PowerPoint.
Now Dr. Sajani is starting.
It's not in slideshow mode, madam.
Yes.
Yes.
Yeah, now it is. Yeah.
A 66-year-old woman. This is Nana Bai, postmenopausal, 26 years back, para-free, line-free, previous 3 normal vaginal delivery. Last childbirth was 4 years back from Trinidad of socio-economic status of class 4. Came with chief complaints of mass descending per vagina since 2 years. History of presenting illness, history of mass descending per vagina for 2 years, which was gradual in onset and progressive in nature. Mass increases on cuffing and straining and decreases on weighing down. History of difficulty in initiation of urination, able to pass urine only after relieving the mass. There is history of increased frequency of mutilation, no history of burning mutilation, no history of urgency, no history of leakage of urine while doing physical activity.
Sajani, what is the commonest urinary problem you come across whenever there is a genital prolapse? There's something unusual like initiation problems. Any other problem usually you come across in all patients?
Increased
Louder.
frequency of mutilation.
Increased frequency and anything else?
First, they will be having what? One symptom only they will be having, and they will be coming and telling.
Retention.
Rather, it will be incomplete emptying rather than retention.
Incomplete
Retention is a very late symptom. So usually they present with incomplete emptying. Okay, that is the commonest symptom because usually whenever the prolapse starts, the bladder neck, the base of the bladder descends and it will be at a lower level than the urethra. So most of the time, the patient complains with incomplete emptying. That is the commonest symptom. And here the patient comes with a different complaint like problem in initiation. Right, proceed.
No history need to manually reduce the mass to defecate. No history of post-coital bleeding. History of coital difficulty present. No history of postmenopausal bleeding. No history of abnormal discharge per vagina. No history of loss of weight or appetite. No history of chronic cough, constipation or mass abdomen.
Why history of constipation is important?
To check any mass is there.
You're asking about constipation.
Why history of constipation is important in a case of prolapse?
Rectocele.
It's a very simple question I'm asking you. Chronic constipation because of chronic increased intra-abdominal pressure. They are stressing too much on passing bowels. That will cause. What are the other chronic causes which will cause prolapse?
Chronic bronchitis. Cough.
Chronic bronchitis and asthma, all these conditions. Chronic cough, any chronic thing, it's going to increase the intra-abdominal pressure, will be the initiating cause of the genital organ prolapse. Okay, proceed.
Actually, chronic constipation causes atrophy of the pelvic floor muscles. Okay, they say a study has proved atrophy of the pelvic floor muscles chronic constipation caused the chronic constipation. There's one study. But the most commonest thing will be parity, increased parity. If a woman delivers normally, after one normal vaginal delivery, she is prone to develop prolapse uterus 4 times. If she has 4 vaginal deliveries, then she is prone to develop prolapse 14 times. So the parity, and then second, you go both as you go to postmenopausal, maybe we can discuss. Second will be postmenopausal, the aging process and deficiency of hormones.
Obstetric history. In 1982, full-term normal delivery girl. She was in labor for 1 day and birth weight was 3 kg, no instrumentation, delivered at Satakulam Private Hospital. Postnatal period were uneventful and she continued to breastfeed exclusively for 6 months and resumed work after 4 months.
She was in labor for 1 day.
Yes, prolonged labor.
Okay.
In 1983, full-term normal vaginal delivery.
In prolapse, prolonged labor, does it have any significance?
Yes, ma'am. It predisposes to prolapse.
What?
Predisposes to prolapse.
Okay.
Why should it predispose to prolapse uterus? That's what she's asking.
Stress on the uterosacral ligament and cervical
cervical
injury.
She's telling injuries, madam. Birth traumas, injuries.
Okay. Is it the cause for this thing? Prolonged labor is one of the causes. But you are telling it is a ligament.
Prolonged second stage. Hello?
Second stage.
Hello?
Don't know whether
Second stage.
labor is for prolonged second stage because you told 1 day of labor.
Second stage.
For second stage, 1 day. That's why I asked you this question.
The prolongation
No,
of
what
second
happens
stage
when
the
second stage is prolonged? Hello?
Ma'am, can you please repeat the question? So,
What is happening when there is a prolonged second stage?
There will be stress on the perineal muscles and stretching of perineal muscles. So it will lead to weakening of perineal muscles.
What do you mean by pelvic floor?
Levator ana muscle, urogenital diaphragm.
actually, it can cause neuro damage also. Okay, there is some neurological problems also during delivery. So because of that, usually there is denervation of the muscles, especially after delivery and due to overstretching, there is denervation. So rather than the quality of the muscles, denervation predisposes to prolapse. Previously, they were telling the stretching, everything, but now definitely there is stretching, and the stretching will cause drop of the levator plate that sags down, that leads to prolapse uterus. Whenever the levator plate is, the tone is maintained, the vagina, uterus, and the rectum, everything all will be horizontal. And whenever intra-abdominal pressure is elevated, it will be depressed over horizontally over the levator plate. Okay? But whenever levator plate sags down, if the intra-abdominal pressure is elevated, all descend down. The vaginal axis gets altered, and because of that, uterus and the vaginal walls all they descend through the vagina to cause a prolapse uterus. So the overstretching leads to muscular, I won't say wasting or dystrophy, but it is neuromuscular damage that occurs usually during labor. And now they have done one study and they are telling, even if you do a cesarean section which is done before the onset of labor can give a protection to prolapse uterus. But if the patient has been allowed to continue for some time during labor, maybe in the active phase of labor, and if cesarean section is done later, even a first trimester uterine contractions and suppose she has a premature bearing down, that can cause prolapse uterus, even if they do a cesarean section.
Okay, proceed, continue to.
Second baby, 1983, full-term normal vaginal delivery, male baby, birth weight 3.4 kg at Satambulam Private Hospital. Postnatal period were uneventful and she continued to breastfeed exclusively for 6 months and resumed work after 4 months. In 1985, it was home delivery conducted by a paramedical person. It was full-term normal vaginal delivery, boy baby, and birth weight was 3.5 kg. Postnatal period were uneventful and she continued to breastfeed exclusively for 6 months and resumed work after 4 months. No history of any instrumental delivery. Inter-pregnancy interval was 1 to 2 years. Past history, non-case of hypertension on treatment and not a non-case of diabetes mellitus, bronchial asthma, tuberculosis, jaundice and heart disease.
And in what way a home delivery is significant? You told last delivery was home delivery. It would have been conducted by an
untrained personnel
untrained personnel.
Perineal injuries won't be featured.
Would not have been sutured. Perineal injury, if it had occurred, would not have been sutured. And then anything else? They would have encouraged, to ask the patient to push, even before full cervical dilatation. Okay, so premature pushing can cause stretching of the muscles and weaknesses.
Family history, nothing significant. Personal history, normal sleep and appetite. History of difficulty in initiation of urine. History of manually reduces the mass to urinate. Normal bowel habits and no history of smoking. Menstrual history, attained menarche at 13 years. Regular cycles, a normal flow. Menopause attained at 40 years, 26 years back.
Now, what are the complications? Why prolapse occurs in old age women after menopause?
Because of estrogen deficiency, that ligaments and supports will relax.
Now, the pathophysiology, why the ligaments should become lax.
The estrogen support is low.
Estrogen support is low. Actually, once estrogen support is not there, what happens? See, there is an alteration in the collagen. There is reduction in the collagen muscle fiber ratio. The collagen becomes deficient. The quantity, quality, and the type of collagen it decreases, and the collagen type also gets altered. So basically, all the vaginal support, the facial support, everything, and the ligamentary support, all the tissues are made of collagen. So whenever there is a collagen deficiency and alteration in the collagen fibrils, that causes weakness of the support, the pelvic support, the levator plate, and that leads to prolapse uterus. Okay, so aging is another important factor. One is parity, second is aging, and third is, as you told, birth trauma, and these are the important. And last is lack of estrogen. Okay, all these causes, and even in pregnancy, this hormonal changes can occur, and alteration in collagen can occur. So parity plays a vital role in the etiology of prolapse.
General examination, patient is conscious, oriented to time, place and person, moderately built and nourished. Height is 162 centimeter, weight 65 kg, BMI is 24.8. No pallor, no icterus, cyanosis, clubbing, lymphadenopathy and fetal edema. Pulse rate is 86 beats per minute, regular in rate, rhythm and volume. Blood pressure 150 by 80, measured in right upper arm in sitting position, respiratory rate 18. Thyroid normal, breast normal, spinal gait normal. Systemic examination, CVS, S1, S2 heart, no murmurs. Respiratory system, normal vesicular blood count heart. CNS, no focal neurological deficit.
What is the significance of examining the spine? Suppose if this woman is a younger woman.
Neural tube spina bifida. It will lead to a prolapse.
So there is some collagen abnormality. Okay, collagen abnormality that can cause prolapse uterus in congenital disorders. Okay, yes. So always look for the spine.
But that type of the prolapse will occur in the younger age itself. It is like a congenital prolapse, like any collagen deficiency disorders or spina bifida lesions, like they will be having the early prolapse. It will be,
Yes.
they'll be coming in the age of reproductive age itself. During pregnancy itself, they will come with the complaints. So many patients I have seen coming with prolapse, second degree prolapse in pregnancy itself. So that should be ruled out. But this case, what are the positive findings in this case to tell these are the causes she had prolapse? Tell one by one.
Menopause.
First, it's her age factor. What is her age now?
66 years.
56.
66 months.
Okay, 66. And then, but you told sexually active?
No.
Okay. So 66 years, postmenopausal. Then anything else?
Previous normal vaginal multi.
Yeah.
Previous
Normal vaginal deliveries, one domestic delivery conducted by the paramedical, and first delivery, prolonged labor. What stage and all we don't know, but prolonged labor, 1 day of labor. Any other thing? Interpregnancy interval is also very important. And what was she? What is her occupation? Every time you were telling 4th month itself, she resumed her duties. What was she?
Housewife.
Okay. Housecore works only, she was.
No, was she lifting heavy weights or strenuous work? That's what she's asking.
Okay.
She's not.
Like lifting weight, like normal activities.
Okay. Housecore works, she was. I was thinking she was working outside, because every time you were telling 4th month she resumed to do her duties. That's why I thought she must be working. Okay. Housecore works. So you mean to say she doesn't have enough postnatal rest like this thing. That's you want to emphasize. That's why you were telling. Okay. And then anything else? With this history, this much only. Okay. Now you proceed. General examination you told. Next. All the examination finished, huh? Tell.
Netra is continuing.
Oh, for general examination, another PG, huh?
No, they wanted to present. They are interested in presenting, ma'am. That's
Okay,
why.
Tell.
For abdomen examination, inspection abdomen scaphoid, umbilicus in midline and inverted. All quadrants move equally with respiration. Sterilization scar seen. No sinus or dilated veins. Hernial orifice free. Palpation, abdomen soft, non-tender. Non-tense, non-tender. No organomegaly, no ascites. Auscultation, normal breath sounds heard. Normal bowel sounds heard. Local examination, inspection. External genitalia appeared normal, sparse atrophic hair seen over the genitalia, and oval pinkish swelling of 3 x 4 centimeters seen protruding to the introitus, with cervix as the leading point. Lugosity is absent, and lateral vaginal sulcus not seen, and no decubitus ulcer or keratinization seen, no stress urinary incontinence seen. In palpation, inspectory findings are confirmed. Cervix is the
Usually,
leading-
stress urinary incontinence will be present in prolapse. So,
Yes,
usually,
ma'am.
usually.
Usually it may be present. I don't complete.
No, actually,
frank-
stress urinary incontinence will be a occult stress urinary incontinence. When you reduce the mass and ask her to sneeze or cough only, she will leak. When the mass is outside, she can't leak. Why? Because there is a kinking of urethra. So it will be a retention of urine. Stress urinary incontinence will be occult. It will be masked.
Yes, ma'am.
If you keep a pessary and she is going to have a correction of the prolapse, and at that time she is going to have a stress urinary incontinence, mean to say, if after the prolapse repair, she may develop stress urinary incontinence. For this, you have to do the repair also. Tell.
Estimate test report. What's the test result?
Palpations in inspectory findings were confirmed. Cervix is the leading point. Mass is reducible, not able to get above the swelling. Mass descends further on cough and straining.
Now, suppose if there is a decubitus ulcer, what will you do?
And we have to wait for healing of the ulcer by chronic daily dressing of the ulcer and
Daily
pushing
dressing of the ulcer.
dressing the ulcer and pushing the
No.
prolapse.
What is that called? It is not the dressing of the ulcer. In prolapse, it is called something else. You will pack, no?
Pack.
With the vaginal pack, reduce the mass, put it inside in position, and then you have to apply any estrogen cream for the ulcer to heal. Okay, you won't keep the ulcer outside and this thing. So packing is very important for healing. What is the pathophysiology behind decubitus ulceration?
Due to prolapse, there will be congestion at the local the cervix, which leads to ulcer.
Because of
Venous-
venous stasis.
Venus, something like
This is-
varicose vein.
Okay.
Suppose if it's not healing, what would you do?
Healing, we have to take biopsy of the ulcer to rule out any malignancy.
Is malignancy common in a prolapse uterus?
It is
Usually not. Usually not. But if the ulcer is not healing, okay, you have to do it. And when will you pack the uterus? When will you reduce and pack the prolapse? Daily you are supposed to do packing, no? With some antiseptic solution, maybe acrylamide, maybe metrogel. It has to be moist. It has to be sterile and moist, and it has to be prolapse has to be reduced, and you have to plug. When do you plug it?
no, mostly it is done in the morning.
Why in the morning?
Usually in the night, the prolapse will be reduced only. So we don't need to.
Patient will be sleeping, and most of the time she'll be taking rest at night, but for going to bathroom. So in the morning she'll be ambulant. So it is the time when the prolapse has got a tendency to come out. So you want to reduce it and plug it usually in the morning. Okay. And what do you do next day? Whenever you do it next day, what is the precaution you take before you plug again?
We have to clean the.
You have to see whether the previous day's plug has been removed, or it is sometimes most of the patients they expel it on their own. Sometimes it may be retained within the vaginal cavity. Without knowing it, you cannot put in a second plug. Okay, so see whether it has come out, and then usually it doesn't happen in a huge prolapse, but in some second degree prolapse it can happen. So see that the previous plug is out, and then maybe you can wipe, and then you can put in a fresh sterile pad again.
The first spectrum examination, bulge noted in the upper two-thirds of the anterior vaginal wall and 6 to 6E, and stage 3 prolapse noted, bulge noted in the upper and middle one-third of the posterior vaginal wall, intrusive and retrosive present. Per vaginal examination, uterus retroverted, normal in size and fornix is free. Per rectal examination, normal rectal mucosa free, sphincter tone is normal. deficient perineum noted, and levator anatome is reduced.
How did you diagnose there is a enterosil and rectosil?
Introsil is seen as a upper one-third bulge, ma'am. And in the middle one-third, it is seen as a rectosil is seen in middle one.
Just by the vision itself, you can tell, seeing and telling it is a enterosil and it's a rectosil.
Which position you will do? Which position you will do?
And
No,
how will
patient
you demonstrate? That is
Tell
more
me how
important.
you
in
will
physical
examine. Tell
examination.
how you will examine.
How will you
Okay.
examine, ma? To
Bone.
find out the
Patient is-
enterosil and rectosil?
Be louder, Netra.
Patient is made to patient is made in lying down position, and the lithotomy in lithotomy.
What lying down position, ma? Just
Which
lying down you
position,
can't.
ma?
There is one position for examining the enterosil and rectosil. If that position is made, the patient, you can easily diagnose. There will be even that this thing you can put a sim speculum and you can demonstrate also. That position is what I have already told you the answer.
Left lateral position.
Yes.
Left lateral
Yes.
position.
Left lateral with one leg up. What is
One
the
leg up.
position called?
Sims position.
Speculum and
Sims position.
basic questions. You have to answer.
Sims position.
Okay. How will you demonstrate in the Sims position?
How do you demonstrate? That's what she's asking.
In Sims position, patient is has to cough by retracting the posterior vaginal wall. When the swelling is from the above downwards, it is enterosil, and it is.
How can you see when the uterus and cervix are blocking the view? What do you do initially?
Valsalum is posterior cervical lip is held with the valsalum, and patient is asked to
Valsalum.
cough.
Valsalum. You never listen to madam's question. Before examining the patient, if the examiner is asked to examine the patient, what will you do first? First, you will see something, and then you will see something, and then you will demonstrate. First, what will you see? Whether you can
Get above
the strength
swelling.
or the mass. Then
Yeah.
you have to
Reduce the small. Reduce the
reducible
swelling.
or not. After reducing only, you can demonstrate.
After reducing and posterior cervix is held with valsalum, and posterior vaginal wall is retracted using speculum, and patient is asked to cough, and slightly, and the speculum is gently withdrawn to see the bulge. If it is from above downwards, it is a enterosil, and further withdrawing, if there is any bulge is seen, it is called as a rectosil.
In digital examination, how will you demonstrate? Is there any examination to demonstrate these two rectosil and enterosil? If it is so, what is that examination called, and where will you feel the impulses?
On a rectal examination, on coughing, the tip of
Rectal
the
examination.
rectal.
Rectal. Rectal, what are you going to see here? Rectal, if you want to see, something will be there. That is called the hooking sign. What is it? There will be a deficient posterior perineal wall, and the finger will be going inside the pelvic. What is it called? Yeah, hooking of the posterior vaginal wall. There only they will use their two fingers to pass the motion also. That is this thing activity is called what? To reduce, to initiate, to defecation. That is called splinting. Splinting. If you want to examine, it should be a rectovaginal examination. It can't be only a rectal examination. If the examiner has asked you to do a PR and demonstrate some hooking sign and all, perineal body, if there is a deficient perineal body, only rectal mucosa, and it is adherent with the posterior vaginal wall, you can see your finger protruding inside the posterior vaginal wall. That is hooking sign. But rectovaginal examination is the digital examination. If it can be done means it can be done to demonstrate rectocele and enterocele. How will you do? You don't know. I will tell you because you told only rectal examination. You don't know what is rectovaginal examination. But nowadays, everything is obsolete. We are doing only POPQ. But in the examination, when the examiners are old, if they ask, you have to tell them the answer. Otherwise, you won't be given marks. So, your middle finger in the anal canal, index finger in the vagina, you do a rectovaginal examination. Ask the patient to stress or strain. When there is an impulse touches on your tip of the finger, it is enterocele. When there is in between the finger is getting bulged, it is rectocele. This is how we were demonstrating. But nowadays, POPQ has come up, and we are doing only the quantitative quantification of the prolapse, and we are telling this is the degree of prolapse. Okay, but you should know what is the position, how you will examine, and what is the hooking sign, and how will you demonstrate enterocele, rectocele. All these are the clinical questions you have to know. Okay.
Yes.
Okay, finish the examination part of it.
Yes, ma'am. POPQ saving.
Tell.
And the point AA is at plus 3 centimeter and point BA is at plus 5 centimeter.
What is normal to this thing of point A?
Ma'am?
Point
What
A.
is the normal? What is the normal?
Point A is 3 centimeter above the hymen.
Okay, it is -3, no? You are telling
Minus 3. That's
that's why
minus
I
3.
asked. That's why I asked. When you told +3, I asked. That's why. Okay.
Minus. The genital hiatus is 6 centimeter and the pelvic body is 2 centimeter.
What is the normal centimeter of genital hiatus?
2 centimeter.
2.5 to 4 centimeter. More than 4 centimeter, more than 3.5 centimeter. If the genital hiatus is very big, it may give way for the prolapse to happen. Okay. And then what are the other points?
Total vaginal length is 10 centimeters. And point D is at plus 4
How will you
centimeters.
measure total vaginal length? Before that, what will you do?
After reducing the prolapse, we have to measure the deepest point in the fornix up to the hymen.
Which fornix? Which fornix?
Posterior fornix.
Specifically, you have to talk. Just like that, you can't tell fornix. Fornix can be anterior, fornix can be 2 lateral, and 1 anterior, 1 posterior. Which is the deepest fornix?
Posterior.
Yeah. So, you will measure from there. Okay. From there to?
From there to hymen.
Hymen. Which place? Fourchette. Posteriorly, there will be a dimple. Till that level, you have to measure. Okay. Then, what are the other points?
AP and BP is at plus 2 centimeter and BP is at plus 4 centimeter.
BP 4 centimeter. Then?
And point D is at plus 4 centimeter.
What is point D?
Most dependent part in the posterior.
This is point D. She's asking what point D.
What it indicates? See, point C indicates cervix. Point D indicates what? Why it's called D? Most dependent part of the posterior fornix. What it will be?
Enterocele. Enterocele.
No, actually, it is a place where the posterior most dependent is the pouch of Douglas. Okay, yeah. Finished all points?
Yes, ma'am.
Okay. From the POPQ quantification, what is your diagnosis? You summarize the diagnosis and tell what is this.
Um, 66 years old, the postmenopausal. Para 3 life 3, previous 3 normal vaginal delivery, 2 institutional delivery, and 1 delivery. With inter-pregnancy interval less than 2 years. In a known case of hypertension with stage 3 uterovaginal prolapse, cystocele and enterocele and rectocele for further evaluation and management.
How will you evaluate this patient? What do you mean by further evaluation? What is the treatment option for prolapse?
Vaginal hysterectomy followed by pelvic floor repair.
With pelvic floor repair. So what are the investigation you will do? Tell, how will you evaluate this patient? Evaluation means what? Investigation. Tell. Management means you have to talk about the investigation and surgery part of it or a treatment part of it. If they ask management, if they ask how will you evaluate, you have to tell the evaluation means investigation part of it. Tell what all the investigation you will do and why you will do.
Complete blood count, sugar and renal function.
Okay, all the routine blood examination will be done. For what?
Patient is posted for surgery and
So top you are doing all the investigations and especially with that you will do blood group also because prolapse is the one condition which will bleed very heavily. So you will reserve blood. For that you will do a blood grouping. Anything else?
Patient is prone to have a urinary infection, so we have to do urine albumin sugar.
Why there is a increased incidence of recurrent UTI in prolapse?
Due to incomplete voiding of urine.
Yeah, incomplete evacuation causes. With that,
there will be stasis and it is a rich medium for culture of infection. So there will be increased risk of infection, recurrent UTI.
Stasis cause recurrent UTI. Okay, then.
For that, we have to do urine albumin sugar and deposit. In the deposit, if percent is more than 5, then we have to do culture sensitivity to rule
Otherwise, also I will do culture sensitivity. Why? To be on the safer side here, when you are doing a prolapse case, if there is a UTI masked or it is asymptomatic urinary infection, you will get it exaggerated after post-operatively. So better rule out. When you are going to handle the bladder, rule out with culture and sensitivity. Okay, then.
You have to do USG abdomen and pelvis to rule out any other mass in the abdomen. And
before that, I will do the chest X-ray also.
Yes.
No? Why? It is first for anesthesia, second for to rule out
chronic cough or bronchitis.
Yeah, chronic lung diseases. Okay. Then?
And in ultrasound, we can rule out any hydroureter or hydronephrosis. In case of chronic, long-standing prolapse of uterus, there will be chronic hydroureter and hydronephrosis.
In chronic? What? Sorry,
in long-standing prolapse, there will be increased risk of hydronephrosis and hydroureter will be.
So KUB, USG, KUB, you will take to rule out hydroureter nephrosis. Otherwise, also in procedentia, stage 3 prolapse and all, there will be some amount of pelvic atelectasis as well as hydroureter nephrosis because of pinking of urethra, stasis. Okay, then why to rule out abdominal masses you told?
There will be recurrence of after surgery. There can be any recurrence or we are not ruled out. We are not ruled out the cause. So we have to. If there is any mass, we have to remove that. Along with that, we have to do the surgery. So to rule out the main cause.
Only that. Any ovarian mass, anything which causes increased abdominal pressure may be the cause for uterine prolapse also. Okay. So you will rule out. Yes, when you are seeing the USG, you have to see KUB, you have to see ovaries, whether it is normal or it is having a ovarian cyst. You will see whether there is a ascites, and then you will be seeing, looking for the uterus. Uterus won't be there if it is the stage 3 prolapse or crosidentia, because completely it will be coming out. Otherwise, you can reduce and see to see what? Endometrium. So endometrium should be seen. Okay. Endometrium, what is the thickness of endometrium? If there is thick ET and with the prolapse and post-menopausal bleeding, then the treatment part is completely different, because before that you will evaluate with the pimples, biopsy, all those things. Okay. Then what all the other things you will do?
Ma'am, can you repeat the question, ma'am? I can't hear you.
So what
Actually,
are
the
the other
connection,
investigation after
the
your
connection was lost,
what are
ma'am.
you
So
going to
actually,
do?
we couldn't understand. Like we didn't hear you. Okay, what is the other investigation you would like to do?
Yeah, what are the other
Oh, the
investigations
image
you
is
will
not
do,
there.
and what will be the treatment?
Ma'am, we have to rule out any other cardiac disease, so we have to do ECG and echo for anesthesia purpose. And then if the patient has completed a she's a postmenopausal woman, so we can proceed with the definitive treatment of vaginal hysterectomy with pelvic floor repair.
When you are talking in the examination, talk about only about your case. You are presenting, you are diagnosing your case, and you are managing your case. In the case of postmenopausal bleeding, in the case of reproductive age group, it won't come there at all. You are talking about your case. What is the treatment for that case? You have to talk. Okay, ma'am? So we are going to poster for vaginal hysterectomy. Yeah? Tell what are the things? Under what anesthesia? What is the repair you will do? And what is ACR? What is PFR?
Under spinal anesthesia, a Wardmeyer procedure is done along with anterior corporaphy and posterior corpoperiduraphy.
First, you will do the this thing ACR.
Yes,
PH
ma'am.
part of it. PH, how will you do? I asked. Everybody knows that is the treatment, but I am asking you the stepwise procedure.
Services held with Valsalam, and then circular incision is made just below the bladder sulcus, and the vertical inverted P incision, and the incision is extended above to separate the bladder.
Where will you put the transverse incision?
Ma'am?
Where will you put the transverse incision, ma'am?
Ma'am, just below the bladder sulcus.
Okay.
And it is extended above and to separate the cervical fascia from the bladder, and the bladder is pushed above, and then vaginal hysterectomy proceeded with the clamping of the procedure clamping of uterosacral uterine vessels, and then
You have to open posterior, without that, how can you do it?
Yeah.
and
You never
posterior.
told about the posterior part. You never opened the posterior vaginal wall. You never inserted any speculum there. Just you proceeded with the anterior inverted T incision, and you are cutting clamping.
And the circular incision is extended posteriorly to open the POD, and the speculum is inserted. And then the peritoneum is opened.
Which peritoneum is open? We have already opened the pouch of Douglas. Now we have to lever out the uterus. No, you have to lever out the uterus and then identify the anterior peritoneum. You have not opened the anterior peritoneum yet. Yes.
And then vaginal hysterectomy proceeded by clamping uterosacral uterine vessels, and then
Only uterosacral?
uterosacral and cardinal ligament. And then the uterine vessels plus Along with that, if you preserve, if the patient is postmenopausal, ovaries are not preserved, so when part of the pelvic ligament is clamped and ligated, and then after removing the uterus, then proceeded with AF anti-corporography by taking the sutures and taking sutures in the tuberculosis patient, bladder dressing is done. Then the extra vaginal tissues are cut and removed, and then the incision is closed. Then followed by the
Which incision is closed? We have not completed it. How can we close the incision? What do we do after bladder buttressing?
You never did the bladder buttressing part of it, huh?
Now she has told the bladder
Okay,
buttressing.
after that,
After that, we have to close the uterine side.
immediately how will you close? So it will be hanging.
Mecus cardoplasty is done to close the entrance, to provide support to the vault and prevent future vault prolapse. And then the uterocycles are taken outside, and the vault closure done. Vault closure done with posterior carpoperineal is done. And for doing posterior carpoperineal, we have to take 3 points, 2 points at the mucocutaneous junction of the posterior perineum, and just above the bulge, we have to take a
These two alleys should be at the level of just below the labium minora. That will be the original vaginal introit, and that will be the lower border, original lower border. The two alley at the mucocutaneous junction, just below the labium minora. And the third alley,
just above the bulge, you have to take the third alley. And then the triangular incision is made. Then the genitals fascia is separated from the vaginal wall. Then we have to suture the levator ani, give the support to the levator ani, and then the perineal screen is closed.
So you talked about the conventional vaginal hysterectomy with pelvic floor repair. You said in your inspection finding, lateral sulcus is not seen. What is the significance of lateral sulcus, and you have not done anything to bring back the lateral sulcus?
Lateral vaginal wall is defective.
So it is a lateral defect. So you didn't tell anything about correction of lateral defect, right?
You have to place the index finger high above the vaginal wall, and you have to take interrupted sutures along the arcotendinous fascia extending from the pubic symphysis to the ischial spine.
So you have to fuse, you have to take stitches, the arcus tendinous fascia and the paravaginal tissue. Take several sutures so that the vaginal wall, the middle third is supported. That alone will prevent lateral prolapse. Okay. So once, if you have done it correctly, the lateral sulcus should appear. Ma'am.
Then,
So she has completed the procedure, vaginal hysterectomy with pelvic floor repair.
okay, how will you follow up with this patient? What is the post-operative complications in case of these chronic?
Due to chronic prolapse, her bladder sensation has been lost with cystoscopy. So we have to catheterize the patient, and we have to remove the catheter until after she has the sensation to void on her own.
How many days you will keep the catheter?
For 1 week.
1 week?
1 week.
1 to 2. 1 to 2 days.
We keep for 3 days. It depends upon the institute. If in your institute they are keeping 1 week, means that it might itself may cause the urinary tract infection. Unless otherwise any bladder fiber teasing or other things, you need not keep it for 1 week and all. 2 days, 48 hours to 72 hours is more than enough.
Is it a routine that we keep the catheter for 1 week, Netra? That's what madam is asking. You are telling about the patient is not voiding, that is what it is 1 week. Otherwise, do we keep it for 1 week? Is that so?
No, we will
What
clamp
is the protocol?
No, we have to clamp the catheter and we have to see for sensation. If she has the sensation to cause her urine, we can remove the catheter after 24 hours to 48 hours.
And what else you are doing after removing the catheter? What else you are seeing?
Post-voided urine is checked. When post-voided urine is more than 30 ml, then we have to reinsert the catheter. If our post-voidal urine is less than 30 ml, we can remove the catheter and we can follow up around after 1 week.
Only when the post-voidal volume is more than 50 ml, then we keep the catheter for 1 week and give rest to the bladder and remove it after 1 week. Okay. That's what madam was asking. Immediate post-op. Okay.
You said something about Meckel's scaldoplasty. What is Meckel's scaldoplasty?
Ma'am, it was
Madam, are we audible? Are we audible, ma'am? Madam, are we audible? Oh, now it's coming.
It is audible.
No, ma'am, not speak to it.
Others are not.
Got disconnected, ma'am.
Oh, cherry, madam.
Ma'am, Hepzibah ma'am is there. Ma'am, are you there? அவங்க டிஸ்கனெக்ட் ஆயிருக்குமா? நம்ம கனெக்டடா தான் இருக்கிறோமா?
We have got a message like you are audible. Only thing externals have been disconnected.
Ma'am, are we audible now?
Meena madam, you are
PG from
audible,
any
ma'am.
other center? PGs from any other center?
You are audible வந்திருக்கு madam ஒரு message.
Oh.
Meena madam, you are audible, ma'am.
Okay. Now you are, Netra, you are telling something about Meckel's scaldoplasty. What is Meckel's scaldoplasty?
It will approximate the uterosecond to the rectosegmoid fascia to operate.
Actually you secure the uterosacrals. You don't approximate to the rectosegmoid. You secure the rectosegmoid in the center. No, you approximate and then tie it. That is called internal. Yes. What is rectal scaldoplasty? External.
Securing the uterosacral and the suture is taken outside and it is approximated.
It is taken outside and it sticks to the wall. Why do you do this step?
Wall prolapse.
What is the other thing you should do to prevent future wall prolapse? Because recurrent prolapse is very common. If you see the women of this age group, they come for prolapse correction, roughly, for 11% of these women come for prolapse. But after surgery, the incidence goes up to 40%. 40% of the women are coming for recurrent prolapse. Okay, so how do you prevent? You have done a vaginal hysterectomy. One is this Meckel scaldoplasty. What is the other step you do to prevent subsequent wall prolapse?
The vault is attached. If you are doing vaginally, what is?
You are doing a vaginal hysterectomy. Don't say you're. That's what madam was telling. You know, we'll have the discussion pertaining to your patient only. So you are doing a vaginal hysterectomy, PFR. So tell what you will do.
The vault is attached to the sacrospinous ligament.
So you do sacrospinocolpopexy. So you do a sacrospinocolpopexy. And also, as you said, you have to approximate the uterosacrals in the center, and then that has to be transfixed to the vaginal wall. So that will pull the wall high. So that should prevent recurrent prolapse. What else you have to do to prevent recurrent prolapse, which you have not told in the steps of your vaginal hysterectomy?
You have to take higher sutures in the peritoneum.
Which peritoneum? Say it is the posterior peritoneum, the pouch of Douglas. No, the peritoneum has to be identified. It has to be secured as high as possible. That you omitted in your step, no, when you are telling. So the pouch of Douglas has to be secured as high as possible. Okay. So several bursting sutures can be taken if possible, or at least one single suture, which has to be as high as possible and be closed. That will prevent recurrent endothelial. So that has to be done. So what are other advice you have to give the patient when the patient is the complication, post-operative complication, one is maybe retention or some bladder disturbance. Any other complication post-operatively? Primary hemorrhage and reactionary hemorrhage. Primary hemorrhage, does it occur in the post-operative period? Primary hemorrhage. What do you mean by primary hemorrhage? Primary hemorrhage occurs during the surgery. Okay, occurs during the surgery. Reactionary hemorrhage can occur up to 24 hours. After we close everything, it can occur. After the BP picks up, after all, the patient is being operated under spinal anesthesia. So before closure, usually we check the BP and then we close. Usually. So after that, if the BP picks up, patient may be having reactionary hemorrhage. So it occurs within 24 hours. So after that, patient can develop. Suppose if she has some discharge, can she have any abnormal discharge from vagina?
Yes, she can have an abnormal white discharge.
She can have some white discharge per vagina. So post-operatively, the patient should be encouraged to have a sterile diaper at least for 3 to 5 days. Because physiologically, post-operative patients may be having some discharge. Okay, some discharge. So encourage the patient to have a sterile diaper. Sterile diaper at least for 3 to 4 days. Suppose if she has bleeding per vagina on the 3rd post-op day or the 4th post-op day. What would be the reason for bleeding on the 4th post-op day? Within 24 hours, 24 hours, it could be reactionary hemorrhage. Occurring on the 3rd or 4th post-op day.
Right.
Because of infection. It could be because of infection. So antibiotics should be continued. And say kind of a culture of sensitivity. The genital swab or the wall swab can be taken. Send it for culture and sensitivity and give broad spectrum antibiotics. Okay. So that should check the bleeding if it is because of infection. What else? Any other complications? Not. Madam, if anyone has some questions or anything you would like to ask.
Sorry, madam, in between my connection went off. That's why I couldn't join.
Yes, ma'am. Yes. So what do we do now, ma'am?
You have 20 more minutes, ma'am.
Okay. 20 more minutes, huh?
Yeah.
Okay. Questions?
Now, suppose if the patient complains of stress incontinence, madam said we will do a pessary test. Okay, we'll do a pessary test and see if the stress incontinence is really because of the prolapse, or she has got an occult stress incontinence. Okay. Occult stress incontinence means the patient will not have stress incontinence when the patient has got a prolapse uterus. Once you reduce the prolapse and keep in a ring pessary, after that the patient will develop stress incontinence. That is called occult stress incontinence. So in such cases, it is not enough if you do just a vaginal hysterectomy with PFR, but we have to correct the stress incontinence too. So what do you do for such cases?
When doing the anterior corporate epidurally, you have to take a Kelly stitch.
So you can take a Kelly stitch. That's the simplest technique. We can take a Kelly stitch. What is Kelly stitch?
To approximate the just below the urethra.
Paraurethral. Okay, paraurethral tissue, and see the bladder neck is held in position. Okay, so that you can do. Anything else? Recent thing which is not done routinely, but as a PG, you must know what else can be done.
Can combine it with transvaginal outside the region.
Okay, you can do, tell fully, don't use abbreviations.
Operator.
So you can use a TVT. Okay, so tension-free vaginal tape. It is called tension-free vaginal tape. What is the tension-free vaginal tape?
This is fast.
That is just a mercilin tape or something, a synthetic tape. Okay, polypropylene tape. Yes. That is inserted. Okay, that is inserted through the posterior vaginal wall to support the mid urethra. Okay, mid urethra, and it is stitched onto the walled high up. Okay, on the walled high up. So that's called TDT. And the important problem, see, you have to, whenever you are doing this, you have to go retropubically, and then behind the pubic symphysis, and then go up. Okay. So the most common complication will be of inserting TDT will be injury to the urethra and injury to the bladder. So to avoid that, you go for transobturator tape. Okay, transobturator tape. So transobturator tape, it goes through obturator. Okay, it goes through obturator fascia. Okay, it goes through obturator fascia. So it is less traumatic. So if you go for a transvaginal tape, okay, tension-free vaginal tape, then you have to do a cystoscopy and confirm urethra, bladder, everything is all right. That's one important thing you have to do. You have to do a post-operative cystoscopy and confirm no injuries done. Okay, so these things can be done. What about the other procedures like STEMIs and RAS procedure for stress incontinence? Routinely, they are not done now. They are not done now. Straight away go for the tape. And what is the important disadvantage of using mesh?
Have a
Mesh erosion, then infection can occur. Okay, infection can occur. So what is the management of mesh erosion? You can't do much. So you have to anticipate erosion, and it occurs over a certain period of time. So whenever you plan for a mesh, you have to go for a high quality mesh. Okay, high quality mesh and a mega porous mesh. So let's say, suppose if you go for a microporous proline mesh, then usually the fibroblast will not traverse through this micropore. So you have to go for macroporous mesh. So if it is a macroporous mesh, the fibroblast, leukocyte, everything can traverse through the mesh, and they produce a fibroblast reaction. So they become pasted to that area and they form a support. Once a mesh is placed, removal subsequently is very, very risky. You can't do it. Okay. So before placing in a mesh, you have to be very, very careful. You have to choose the correct site, choose the correct procedure, and it has to be inserted without any kinking or without any contraction or without any folding. It has to be done very correctly. Once inserted, it can produce. What are the complications? What is the problem on the patient, or what complaint the patient will tell? Suppose if there is a problem with the mesh, the patient will have persistent pain. Okay, she will have persistent pain. And another important thing is dyspareunia. Okay. So you never use a mesh in the posterior vaginal wall. Anterior vaginal wall repair can be done with mesh. Okay. But posterior vaginal wall repair should not be done with the mesh. There's a rule. Okay. So and mesh removal is very difficult. And if there is any complication with the mesh, subsequently you'll have to do some corrective surgeries. Corrective surgeries, right? Madam? Madam, may I ask?
Some other sound is coming now.
Madam, we were discussing. Were we audible?
You are audible, ma'am.
Okay, so we were discussing about the mesh repair, ma'am.
Ma'am, you proceed, ma'am.
Okay. Okay, suppose if the woman is young. Okay, if the woman is young, or no, she comes with the wall prolapse subsequently.
Correct or prolapse very
So you have to do, suppose if the patient comes with wall prolapse subsequently, you go for abdominal sacrocolpopexy. What exactly you do with that surgery?
The Y-shaped mesh is taken. It is the round arm of the Y is attached to the anterior longitudinal ligament, and the short arm is one short arm is placed in the anterior.
PGs, please talk a little loudly.
Sattama Besana, so I have to be louder. Only then it will be audible. Repeat again. Madam, my question was, suppose if the patient presents with subsequent wall prolapse, what is the management? And she is telling now, ma'am. Yes,
ma'am.
For it, abdominal sacrocolpopexy is done. In this, mesh is taken, which is shaped like a Y, and the long arm is attached to the anterior longitudinal ligament, and the
anterior longitudinal ligament of
sacrum.
That you have to tell now.
And the short arm is attached to one arm is attached to the anterior vaginal wall, and the other arm is attached to the posterior vaginal wall. This can pull up the wall too.
This can pull up the vault. Okay, this can pull up the vault. So patient can be symptomatically free. It's one corrective surgery which is done, and you've got other mesh surgeries also, but this is the easiest method. Okay, this is the easiest method and less traumatic to the patient that can be done. Okay. Suppose what is the management of prolapse uterus in a younger woman? Suppose if this patient is just 40 years old and she comes with the prolapse uterus, okay, say second degree, and she wants to retain her uterus. Okay. She has completed family, but still
can go with the Fothergill's or Shiroska's modified Fothergill's.
What is Fothergill's?
What is Fothergill's?
In Fothergill's, the cervix is dilated. The retains.
No, what is Fothergill's?
What is Fothergill's? Still what you are doing?
I never asked how will you do Fothergill's. I asked what is Fothergill's. Fothergill's is the surgery. What you are doing in that? Cervical? Yeah, tell no.
Tell.
Cervical amputation.
That's what
Fothergill's. Fothergill's enna keta, you have to tell cervical amputation.
Cervical amputation.
Which is done for the second degree UV prolapse where the patient is younger. So she wants to retain. I will do Fothergill's. Fothergill's is nothing but a cervical amputation. That's it. It is a cervical canal is amputated and there will be a little bit of cervix if needed and uterus will be there for the purpose of menstruation. Yeah. And for her satisfaction, she will be menstruating for that only. Then they will ask her, what is Fothergill's na ketita ida sollita. They will know, yeah, you know the subject. Otherwise, if you tell starting itself surgery na, what is Fothergill's, you have to tell definitely. Okay, ma. Now you tell what is the procedure.
Ma'am, the cervix is dilated and the cervix is separated. Until the cervix is separated to the uterosacrals, and then the uterosacrals are.
Why you dilated the cervix?
To prevent any hematometra in the future, and proper drainage of menstrual bleeding.
Okay.
And then the cervix is separated at the up to the uterus atrius. And then
There is one more reason for dilating prior
Yeah, one
dilatation.
more.
of the
That's what
cervix.
I was expecting. One
You
more
should
reason
take the
to dilate.
stitch.
Huh?
Follicle stitch is take the follicle stitch properly.
Is it Fothergill stitch? Fothergill stitch doesn't enter the cervical canal. Take the round of sutures. Yes.
Take the round of sutures properly.
You have to pass in the needle.
You have to pass the needle through the cervix anterior.
But before cervical dilatation, there is one important step which you have not told. See, you can amputate the cervix only if it is long. Won't you measure the length of the cervix? So length of the cervix has to be measured, and you have to mentally prepare how much you are going to leave behind, how much you are going to take out. Right? So length of the cervix should be measured. How will you measure the length of the cervix? It must be audible, not to me. So speak louder.
Uterine sound is introduced to measure the cervical length. Normal length 4 to 5 centimeters.
First, what do you do with the sound? Inserted transcervically into the cervix, okay, into the cervical canal, and then the resistance you feel when you cross, when you go beyond the internal os, that length is measured. And then you take out the sound and you measure the intravaginal portion of the cervix. Okay. So if you subtract that, that will give the supravaginal portion of the cervix, that the length of the cervix, and what exactly is the intravaginal portion of the cervix. You can remove only the intravaginal portion of the cervix. In younger prolapse, usually it will be the intravaginal portion which is elongated. In a long-standing prolapse, old age prolapse, and the entire
How will you
cervix may be
differentiate infravaginal elongation and third-degree venous prolapse? There will be one specific test. How will you differentiate, ma'am? How will you measure actually? Unless otherwise there is an enlarged, elongated cervix, you are not going to do. So, what will you do? How will you measure? From where to where and from where you will minus it?
The uterine sound is inserted transvaginally. The first resistance is measured. And,
Hello, am I audible?
Yes, ma'am. From the uterine sound is inserted transcervically, and the first resistance is measured. Measured, and then the uterine sound is inserted both the posterior fornix and the posterior fornix, and the length is measured. You have to subtract for the total vaginal length with the
total vaginal length. You are measuring the cervical length.
Total we have to measure the cervical length and subtract the measurement taken in the posterior fornix. We can get the supravaginal cervix.
I will ask 5 minutes, ma'am.
Then was it audible, ma'am?
Audible, ma'am.
Oh, okay.
You are loud and clear, ma'am.
Finish off father kills. Okay. You measured it, that's why you are going to amputate. So for that also you need that cervical dilatation to insert the thing to measure it also. Tell. How will you finish it off, the surgery?
Tell surgical steps.
After amputation, the uterosacral, the follicle stitch is taken, and the follicle stitch is taken from the vaginal mucosa and to the cardinal ligaments, and then the anterior wall of the cervix, and then the other side, the cardinal ligament and the vaginal mucosa is taken, and the knot is closed. This is followed by the cystocele again, anterior corporate.
So you have taken this further gill stitch and you leave it like that. You have amputated the cervix and cervix will be bleeding.
You have to approximate the anterior posterior vaginal.
You have to do what do we call it? Do you suture the anterior vaginal wall to the posterior vaginal wall?
No, anterior. Suture to the.
What is the name of that suture?
That's only called what?
Strummed off sutures. That is for
New, sorry.
Creation
New
of what?
formation.
Creation of what? What you are cutting and what you are creating.
We are new cervical lip formation.
Yeah, cervical. If the patient is 75 years, she is not going to withstand the surgery. And what will be the surgery? I am asking what will be the surgery for this patient who can't withstand vaginal hysterectomy, ACR and PFR.
Leafport surgery. Can you leafport surgery called for crisis too?
Leafold's calfoclysis. What do you mean by calfoclysis?
Anterior vaginal wall, anterior vaginal epithelium is removed and the anterior vaginal wall
Approximation of the
is
anterior and the posterior vaginal wall to make it as completely closed. Before that, some investigation is mandatory. What is that? Huh?
You have to rule out any carcinoma cervix or endometrium.
No, carcinoma cervix, you want amputate and this, do a surgery at all. Before that, you have to take the pipette to rule out endometrium. Madam, mute பண்ணுங்க madam. சத்தம் வந்துட்டே இருக்கு.
அதெல்லாம் பண்ண மாட்டீங்களா?
Shweta, ma, appa yes.
Somebody else is continuously talking. So, you will rule out endometrial CA by taking pills and then rule out. If there is any endometrial hyperplasia or any ET thick, any little amount of doubt is also Leafold's calfoclysis, you won't do. So that's why you have to rule out that first and then you have to proceed with the surgery. What are the complications of Leafold's?
No.
Complication என்னமா இருக்கும்? You are closing completely. So patient may if have secondary infection, pyometra, all those things, collection of fluid inside and secondary infection is very, very common. So rule out everything, give a coverage of antibiotics even after doing a Leafold's also. Thank you, ma'am.
Thank you, ma'am. Thank you, ma'am. Very nice, ma'am. Very nice having you all.
Yeah,
Thank
very
you so
nice,
much.
very nice. Thank you. Even the PGs have prepared nicely. Thank you, ma'am. Thanks a lot.
Thank you so much. Thank you. Thank you, ma'am.
Ma'am, next week, next month, Sampath Kumari, ma'am. Next month, railways pandro, madam.
Oh, what topic, ma'am?
Any topic, ma'am. Whatever you
Any
tell,
topic.
we'll do.
Okay, okay.
Okay, ma'am.
Okay.
Thank you very much.
எது முடிக்கலையோ அது சொல்லுங்க மேடம். We'll do it. Okay. Thank
Okay,
you,
ma'am. Okay.
Yes, ma'am.
Thank you, ma'am. Thank you so much.
Thank you, ma'am. Thank you very much. Thanks. A special thanks to the faculty for making it very, very interesting and a lot of exam-oriented questions. I'm sure the postgraduates who attended today have been immensely benefited from this. And once again, I thank all of you for logging in.
Thank you, ma'am. Thanks a lot.
Thank you.
Thank you.
Bye, girls. All the best.
Thank you, ma'am. Thank you.
See, little bit of confidence is very, very important. Okay. When you are presenting, be confident enough because they are going to give a pass only to tell that.
சொல்றாங்க மேடம் ஆனா அந்த பயந்து மெதுவா
ஆமா ரொம்ப பயப்படுறாங்க மேடம். அதுக்கு தான் நான் வந்துட்டு I wanted to give this pep talk for them. They know the subject but they are very, very scared. I don't know why. This is only webinar. அப்ப டைரக்டா பாக்கும்போது என்ன பண்ணுவீங்க? So start presenting case each and everybody one ஒருத்தர் கூட ஒருத்தர் பண்ணிட்டு make yourself highly fluent with the conversation. Then you won't have any fear in examination. Seriya? So if you present to her and she will listening means she will be asking questions. She will be listening. She will be knowing what you left. Like that, it has to be always talking. Clinicals is nothing but talking. You have to present to some other person, thinking that even the cooked up cases also you can present. But continuously, when you present only, you will get the habit of talking, ma. Okay? You are finally a teacher.
Yes, ma'am.